start with this particular session. Today we have around 15-16 MCQs on the trauma. And Alpina, that leaves you. So I think you will have to answer. Okay. I hope you're ready for it. You can unmute yourself. Okay. It's just you and me, so we can obviously have a word. Okay. Let's start. Alpina, can you unmute yourself?
Good evening, sir.
Good evening. Hi. Yeah. So let's kind of do it in a rapid format. Okay, there are around 15 MCQs over here. And yeah, we are going to discuss in like 45, 50 minutes. And the whole point of the discussion is not going to be just the MCQ. We are going to talk about that particular topic in a brief manner. Okay. Now, the first question which we have is emergency airway in the severe maxillofacial injury is what? What is an emergency airway in the severe maxillofacial injury? Is it A, cricothyroidotomy, tracheostomy, orotracheal intubation, or the nasotracheal intubation?
Tracheostomy might be, sir.
Tracheostomy, right? Okay. So what you need to, okay, first of all, why didn't you go ahead with the orotracheal or a nasotracheal intubation?
Already in maxilla injuries, the orotracheal or nasotracheal intubation would be difficult.
Okay, I have a fiber optic scope. Okay, you were saying in the orotracheal intubation, okay, you're saying maxillary fracture will be there. Okay. So if at all there is a maxillary fracture, what's going to happen? Like, what's the main problem, like, which you can encounter?
The positioning of tongue, sir.
No. So what you need to understand is many times the severe maxillofacial injury is also associated with the base of the skull fracture. So if you're basically trying to intubate, sometimes your tube might enter into the brain parenchyma and it might obviously cause a disastrous effects into that. So in the severe maxillofacial injury, nasotracheal intubation is absolutely contraindicated. Okay. Orotracheal intubation, they say that a single gentle attempt. Okay, if you want to give, you can give, but not preferred. Okay, not preferred at all. Now, coming to between tracheostomy and the cricothyroidotomy. Okay, what is the emergency airway?
Cricothyroidotomy.
Because of the name emergency. Even if you are, let's say, the best trauma surgeon in the world, let's say if at all you are at the airport and if at all somebody has a fall or something like that, some trauma has happened, now you want to kind of establish the airway into this patient. You're the best trauma surgeon in the world. Can you do a tracheostomy over there?
No, sir.
You don't have the equipments, don't have the basics of the instruments and everything, right? But if you want, you can still perform a cricothyroidotomy with the basics of the thing. You can just give an incision and you can put a tube through the cricothyroid membrane, and that is what is going to serve your purpose. So in the severe maxillofacial injury, what you need to understand is there are two things. One is what we call as an emergency airway. What is it going to be? It is going to be a cricothyroidotomy. But if at all they ask you definitive airway, then what is going to be the answer? Tracheostomy. Okay. Now, another question for you. Why do you need a tracheostomy? So cricothyroidotomy, you understand what is a cricothyroidotomy? There's a cricothyroid membrane between the cricoid cartilage and the thyroid cartilage. What you're basically doing is you're passing a needle through this cricothyroid membrane. So what is happening? The needle is basically entering into the whatever the area, and then you are able to kind of pass the oxygen or whatever you want to pass. Okay, fair enough. Why the hell do you want a tracheostomy in these particular patients? Can you keep the patients on cricothyroidotomy for, let's say, a couple of days?
No, sir.
No? Why?
I don't have an idea.
Just think, because you're only here. So obviously I'll ask you only. Anyway, so don't, it's absolutely fine. Okay, so just relax. Cricothyroidomy, if at all, you kind of keep it for a prolonged period of time. So the time which the cricothyroidomy gives you is around 30 minutes. After 30 minutes, what is going to happen? There's going to be a CO2 retention. Okay, because
sorry, sir, there was a net issue, sir.
What?
Network there issue. Was internet issues.
That's fine. So here what is going to happen is that there's going to be CO2 retention after 30 minutes because it's a single tube, right? So it's just the in-way. The CO2 will not be able to come out. So there will be going to be CO2 retention, which is obviously not going to be good for these particular patients. So ultimately, you will have to do a tracheostomy. But let's assume that you are in the middle of the road or at the trauma scene, or let's say in the airport or something, then you would perform a cricothyrotomy. You would have seen this in few of the movies or something like that, people performing some cricothyrotomy in the airports and all this, right? Then can move on to the next question.
Yes, sir.
Yeah. Okay, good. So the next question which we have is this: Glasgow outcome score of 3 is associated with what?
Severe disability, sir.
Severe disability. So you have heard of the Glasgow outcome score?
Yes, sir.
Is it same as Glasgow coma score?
Oh, I thought it was Glasgow Coma score.
You thought it was Glasgow coma score.
Yes, sir.
My bad. I kind of put 3. I should have put something else. Okay. So the point which I'm trying to make over here is that there are 2 scores. So sometimes what they had asked you was persistent vegetative state. Okay, persistent vegetative state, like this has the MCQ which was asked in like previous times. Persistent vegetative state is what Glasgow outcome score. Okay, so that was the question which they asked. The answer over here is 4. Okay, so that is what we need to understand over here. Okay, so this is what is your Glasgow outcome score. Okay, so this is what you're seeing on the thing. This is what is the Glasgow outcome score. So just kind of go through this. Here, there is a severe disability. The 3 is the severe disability, that's fine. But yeah, this is what is a Glasgow outcome score. Now, this is what is your Glasgow coma score. They are 2 different. Okay, so they both these things are kind of given in your Love and Bailey. So obviously, we are aware of this Glasgow coma score, but do go through this Glasgow outcome score as well. That is again something which is important.
So
Understood?
where is it used, sir?
It's
The
like
outcome score?
not that commonly used. It is just for the MCQ kind of thing. In our day-to-day practice, we hardly use it. Okay. But because there's a table which is given in your Love and Belief, they might ask. That's the only thing. They have already asked you once. Okay. Not in the NEET SS, but in the NEET PG, they had asked. Okay. So that's where you have to kind of go through it. In our day-to-day clinical practice, what we basically use is a Glasgow COPAS. Okay.
Okay, sir.
Okay. Now let's kind of ask you a couple of questions on the Glasgow coma score. Okay. Now I tell you that there is a patient who is coming to you after the road traffic accident. The patient is able to, let's say, what about the eyes of the patient? Okay. So let's say the patient is opening eyes spontaneously. Spontaneous eye opening. Okay. Patient is tracheostomized. And patient is able to localize the pain. So what is the Glasgow coma score of this particular patient?
Before VTM 5, sir.
What? E is 4.
E4, sir.
Uh-huh. V?
Intubated cases, we mention it as T, sir.
Okay. May mention is at T. Okay. And what about the M?
M5, sir.
Okay. So what does this T means? Like, does it mean that the, okay, so if you want to kind of add this, like, if I say out of 15, what is the score?
9, sir. 9.
9. You won't consider it as 10, or let's say something else, like V, you will not give any value to V?
No, sir.
Yes, right. You will not give. Okay, I was just trying to confuse you. The answer is going to be 90 by 15. Okay. So sometimes the students can think that, you know what, tracheostomy patients take V as 1 or take V as 5. No, not really. What you need to understand is VT or VNT, non-testable. Okay. So or tracheostomized. Okay. So obviously the answer is going to be the 90 by 15. Okay. That's good. Okay. Now, this is just a GCS. I'm pretty sure that you are aware of it. And yeah, you should know this by heart. Okay, I hope you know this, because practically in every emergency you might be expected to kind of calculate the GCS for and number of head trauma patients. Okay, so that's all fine. Now, early total care. There's something which is called as an